Hello, everyone, and welcome to the UHN Foundation COVID-19 virtual Q&A live stream. We hope you're staying safe and taking care of each other during these challenging times of the pandemic. I'm Christian Coté, host of the UHN podcast Behind the Breakthrough. We're glad you could join us and grateful to you, our family of supporters who've been so generous throughout these past 2.5 years. So a big thank you from the UHN Foundation and all of Team UHN. On today's episode, we dive into the seventh wave of the pandemic, how infectious is the variant that's driving this wave, the increasing risk of reinfection, and when to get your booster shot to protect yourself against this new virus. As always, we'll feature your questions a little later in the program, but up first, we have Dr. Alon Vaisman, UHN Infection Protection and Control Physician. Welcome, Dr. Vaisman.
Thank you for having me.
And a programming note, Dr. Angela Chung, a clinician and senior scientist who specializes in long COVID, was scheduled to join us today, but she is under the weather and unable to be with us. Okay, lots to unpack on this episode, Alon. We're in the seventh wave of the COVID-19 pandemic. The Omicron Ba5 variant is the dominant strain in Ontario. Talk to us about, first of all, the transmissibility of the Ba5 strain.
So with this wave, we're seeing a lot of cases similar to the most recent wave, not quite as high yet, and we don't expect the wave to be at not nearly as high for now. But the strains that we're seeing related to Omicron have become increasingly more and more transmissible. And this is thought to be due to the fact that this BA.4/5 has more immune escape than the previous strains. So this has been an important feature of Omicron since the beginning, since it arrived in November, December of last year, and continues to be an issue as we've seen more and more strains. What that means is, in effect, is that there's a higher proportion of people who can be reinfected with COVID compared to previous strains. And what it means is that the vaccine isn't doing as good of a job as protect you against the short-term effects of COVID. That is to say, having COVID, picking it up and not having severe disease. For the severe disease side of things, the vaccine is still doing a very good job of protecting you from dying or for being hospitalized.
So when you talk about this reputation that the BA.4/5 has of evading vaccine protection or even previous infection or protection that we assume comes from previous infection, how does that drive this strain of the virus?
So what it means is that even though a large proportion, several million people just had COVID between January and June over the course of the last two waves, some proportion of those individuals will pick up COVID again. It is likely that reinfections are not as severe as the first infections, although there's no guarantee of that. But it means that there's more and more cases. So that's unfortunate because it still means that we're going to continue to have waves and waves of COVID. On the positive side, we are not seeing a high level of morbidity and mortality associated with waves that preceded Omicron, which were more severe. So for example, Delta, the Alpha Delta wave that we have last year between January and May of last year, that was associated with a higher degree of mortality than this wave is. So far, although there is more transmission, the mortality rate remains low. This appears to be the case here in Canada, and it appears to be the case in places that have already experienced a BA.4/5 wave in South Africa and Western Europe.
And what are you seeing, Alon, in terms of symptoms and severity?
So it's still the common symptoms of COVID are in common with this wave, with this variant and other variants we've seen before. Perhaps sore throat may be more of a common experience that patients are having, less the trouble with smell and taste, but it still could very well present as that. So you still see the spectrum, people who are experiencing a mild illness with sore throat, runny nose, headache, and then the more severe form of the illness, usually in people who are elderly and usually in people who are immunocompromised, that is fever, shortness of breath, difficulty ambulating, fatigue, and those patients requiring hospitalization.
And that's my next question. In terms of hospitalizations, the profile of patients you're seeing who need to be hospitalized in Ontario, what's the age group typically and their vaccination rate?
The overall spectrum of disease in COVID remains the same in terms of the age distribution. It is most dangerous in those who are over the age of 80. And as you go down in age, there's less and less risk. There is a small increase in risk in those aged 0 to 5 in Ontario. And the lowest age group in terms of risk is 5 to 11. But as you age from that point on, the risk goes up and up and up. And also people who are immunocompromised, the risk continues to rise. The overall proportion of people who are getting sick and being hospitalized is comparatively low compared to last year. So for example, here at UHN, we have somewhere in the range of 40 to 50 admitted patients currently, and a very small proportion of those, about 10% of those, are requiring ICU admission. In terms of the proportion that are vaccinated, it's important to realize that because more than 90% of Ontarians have 2 doses of the vaccine, the large proportion of patients who have COVID are simply going to be vaccinated. That's just the reality. But even still, even though majority of people who have COVID now are vaccinated, sheerly because of numbers, still the ones who have the most severe outcomes are the ones who did not get vaccinated at all. So that remains an important risk factor for severe disease.
Okay, and this brings up now, I think one of the biggest questions on everyone's minds these days in terms of, you talk about how Ba5 strain of the Omicron variant is evading protection. So that's everybody's asking, okay, well then is getting a booster or getting the vaccine even of use to me?
Yeah, it's important to recognize that a vaccine in this context has 2 important impacts. One is to protect you against severe outcomes such as hospitalization and death. The second is to protect you against mild disease and simply picking up the virus and transmitting it onwards to other people. In terms of the first impact, if we go back to 2 years ago, actually to both of them, both of those numbers are around 95%, protecting you against mild disease and severe disease. Now, what's happened is that the protection against mild disease is no longer that good, and you're able to pick up the virus within a short time after being boosted. Somewhere in the range of 3 to 6 months, your immunity is almost down to 0 in terms of the effect of the booster for mild disease. However, having had a booster, for example, a 3-dose series, and even young and healthy people, that confers a high level of protection against death. So the purpose of the 2+1 booster or getting a 4th booster is to protect you against dying. That is the most important thing that it can do, and it continues to have a very, very good impact. So even in those people who had their 3rd dose a long time ago, even though their immunity has waned against protecting against very short-term disease, they are still protected against dying. And that's really the most important message, is that everyone should have at least 3 doses in Ontario, and everyone who is elderly and immunocompromised should have at least 4 doses in Ontario. And that's to protect you from dying.
Okay, and if we can just do a little deeper dive here in terms of timing, because a lot of people are asking about the timing of the booster. I imagine age plays into this as a factor too, but some are, you read some publications where they say wait until the fall when perhaps there is an upgraded bivalent version of vaccine available. Some say no, get it now. What's your advice?
Yeah, it's a tricky one because unlike the very first time we got vaccinated in January 2021, there isn't as clear an answer about getting a 4th dose. So if we focus in on 4th doses in young and healthy people, age 18 to 60 who are not immunocompromised, what is the benefit of a 4th dose in that group? So in that group, does it prevent you from dying? Is there added benefit? There is a small incremental benefit. Already the risk is quite low in the 3-dose group, but there's a small benefit added to that. So not a significant one. Does it protect you against the mild disease? It certainly does, to some degree, but only for a short period of time, for only a few months, and then it wanes, unfortunately. So the timing really depends on when you want people to be protected against that picking up the infection. When do we want a large number of people protected against picking up the virus over a short term? The ideal time is October, because that protects us going into the wave that we expect to have, as we have every single year with respiratory viruses, even pre-COVID, in December and January. That's part of the reason why we get flu vaccinations in that year, because we expect a high number of cases. So certainly, as NACI has recommended, as the European CDC has recommended, a dose in October makes a lot of sense. Does a dose in July going to help you? It's probably going to have a small benefit, and it's probably going to protect you for a few months. The key thing to keep in mind there is that if you do get a dose in July, don't forget to get a dose again in October, when again, we expect a high number of cases, or October, November, around that time, a high number of cases to arrive again. This wave that we're in right now is not going to be alleviated by vaccination that was just rolled out last week in this age group, because it's a very short time frame and it's likely going to peak very soon. So there isn't much downside to getting vaccinated at this moment. But the main key thing, the message that we should be putting out to people is that regardless, you should be vaccinated going into the winter season.
Very good. You mentioned reinfection and how this strain is successful at evading previous protection. Does that mean that there is no conferring of immunity or buildup of immunity if you've been infected before? Because we read a lot about this sort of thing that, oh, I had COVID, so my antibodies are right up there.
Yeah, absolutely. If you've been infected before or you've been vaccinated before, you are still to some degree protected against picking up the virus now. The reinfection rate still remains low. That's for sure. It's hard to estimate what actually that reinfection rate is, but it still remains low overall. The problem is that with BA.4/5, the reinfection rate is higher, is presumed to be higher compared to previous strains, certainly higher compared to the pre-Omicron strains where reinfection was very, very low, less than 1%. But when Omicron arrived, reinfection became more and more common. So that's really what it boils down to. But two important things that we think about in terms of consequences of picking up the virus. One is severe outcomes like dying. You're still very well protected if you've had infection before and survived, or if you've been vaccinated before. And the chronic inflammatory response or the chronic inflammatory consequences associated with COVID, that is also reduced by having been vaccinated too. So, for example, multi-system inflammatory disorders in children, that is reduced by having been vaccinated. So even if you do get exposed, your likelihood of developing that is still lower. And that's an important message, is that even if reinfections do happen, the morbidity is reduced by having been vaccinated.
I'm curious about reinfection also, though, in terms of just what kind of toll does it take on your body and your immune system if you get it 2 and possibly 3 times?
That the answer to that question is unclear. There isn't any definitive evidence to say that reinfections are necessarily going to be worse. We just simply don't know. In some people, a reinfection may be worse. In some people, it may be the same or better. The one aspect to all of this is to recognize that those who are unfortunately the most susceptible to dying as a result of COVID, unfortunately, they died of COVID in the first wave and the second wave and the third wave, resulting in a population that has survived that is less susceptible to dying and having complications. That is unfortunate that those individuals passed away in that phase of the pandemic. But what it means is that the people who have reinfections now are by definition people who have survived their first infection, which means that they're likely to have less severe disease as a total proportion of the population. So just important to recognize, we don't know what the immune response is to repeated infections. If we take the example of other coronaviruses, for example, the ones that circulate every year and cause colds, that would suggest to us that repeated infections do not result in chronic disability, that people are just fine, because we know that on average, people pick those up perhaps one every year or one every 2 years. So per repeated exposures that we've had for our entire lives against other coronaviruses that are now mild do not result in any sort of severe immune deficiency or immune response problems.
Okay. And I've been reading where cases, there's people who are testing positive for weeks after being infected. Are they infectious throughout this entire period?
As far as we know, the best research suggests that the infectious period still remains relatively short, in the range of 10 to 20 days in most people. With Omicron, it appears to be longer than it had been in previous strains, but still it's not in the range of weeks. It's not likely to be very long. So this is based on data looking at what's called cycle thresholds and testing the viability of the virus. What can occur with people is having repeated positive rapid antigen tests. It's unclear how far out that still correlates with infectivity. But for example, in the infection control world where I work and we monitor patients closely and discontinue their isolation, for example, after having COVID, with a practice of still using 10 days, we're still safe. So even though people are testing positive on their rapids, it's not necessarily the case that they are still a high degree of infectivity, especially if their symptoms have resolved. If patients have persistent or worsening symptoms at 10 days, then it's certainly possible that they're still infective at that phase. It's uncommon as an outpatient to have that. Most people have resolution of symptoms by that point.
So obviously we have vaccines as a protection. What's your recommendation for additional protection when we're out in public these days in terms of, say, large gatherings, indoors at a shopping mall, et cetera?
It all depends on the prevalence of disease in the community. Currently, over the course of July, we have a rising prevalence of disease. We have more and more COVID cases right now, resulting in more and more admissions, as we've talked about. In that case, it makes sense to use a higher level of precaution. So going back to the thinking that using a mask in tight indoor settings or places that are not well ventilated certainly makes sense. If the community prevalence is extremely low, there is little added value to wearing a mask. This unfortunately hasn't been the case for a while, because between our last wave and this wave, we didn't really even see much of a nadir at all. It kind of flowed into one another. So there wasn't really a break for us, unfortunately, and really unfortunate that summertime we're still having cases, even though the last 2 summers we didn't. As for outdoor settings, they remain very safe. It is very unlikely to pick up COVID due to the circulation of air in outside settings, and masking is not necessary. The exception is if you are in an outdoor setting that is very close, where you're close to one another. For example, there's a lot of people waiting for the bus in one tight area. It makes sense to mask if you're very close. Otherwise, if you're out in the park or out on the playground with nobody near you, there's no added value to masking in that setting.
Okay. And in terms of treatment, say if you do get sick, there's treatments such as Paxlovid. Are they having an impact in terms of reducing symptoms, reducing the run of the virus?
The best evidence we have with Paxlovid is that for those who are unvaccinated, getting that drug in the 5 days after symptom onset within that time frame reduces their likelihood of having severe outcomes. And that's the purpose of giving that drug. In Ontario, the drug has been rolled out to an even broader audience, a large number of people, even who are vaccinated, with a lot of comorbidities. The problem is that we don't actually have any evidence that tells us whether it is or is not beneficial in the fully vaccinated group of people, 3-dose or 4-dose people, for example. But it does have an impact among the unvaccinated, and that's what the research shows us. So that's really where the gap in the knowledge is right now. In Ontario, they erred on the side of extreme caution in one sense, you could say, by rolling it out very broadly, having many, many people have access to the drug. There are some other concerns, is that the drug has interactions with other medications that people may be on, and the drug has a few side effects, mostly stomach upset and that kind of thing. But that drug could potentially be beneficial in a subpopulation who are likely to be admitted.
And what can you tell us, Alon, about this wave in terms of peak and forecasting in terms of the length of this wave, how long it'll go on for?
Yeah, it's, as always, waves appear to be symmetrical in their shape. So if you look at the South Africa wave, their experience that often mirrors ours in terms of the length, they saw a wave rise and fall in approximately the same time frame as we've seen here in previous waves. So in the range of 4 or 6 weeks and that kind of thing. So right now we're looking at perhaps a peak in a week or 2 weeks from now, and then a fall during the month of August. That's the rough estimation that we could say for this time around. The total number of cases doesn't seem to be reaching what we just saw in the waves just prior to this, but we're looking at something like that. And added to that, it's important to think about how we're going to approach this whole problem in the future in a sustainable way, because we keep focusing on numbers and waves, but it's really critical to understand that this is just going to be the future, that despite very good mitigation efforts, we are going to continue to see COVID waves. It's just going to come and go. These waves are going to be more severe in the winter and less severe in the summer. But the key thing is to try to figure out strategies to try to reduce morbidity and mortality.
Do I have it right? The next strain has already been identified as Centaurus?
Well, that name was just coined by some random person on Twitter, actually. But that speaks to the point that we are likely to see more variants. It's every time a new variant comes out, it makes news, and people are asking, what is it like? Is this going to evade the immune system, evade the vaccines? Fortunately, I think the important thing for people to recognize is thus far we have not experienced a single variant that has completely evaded the effect of vaccination. So far, vaccinations remain effective at protecting you against severe disease. Not so much against mild disease. I mean, of course, there's always some degree of infection that's still associated with it, but protecting you against dying, they still do that. That's really the main reason we should get vaccinated overall. From time to time, the reason a booster should be taken for younger and healthier people is really for that short-term immunity, protect a large number of people in a short period of time. That's really the main benefit for the vaccine in that setting.
So this cycle of the COVID virus mutating into something new and we get wave after wave, is this something we're looking at for many years to come?
Yeah, it's hard to know, but there's no sign of it abating at this point. What are the variables that are going to reduce the likelihood of cycles occurring in the future? For one thing, on a global scale, is that more and more people are vaccinated, so there's less and less chance that a variant will show up somewhere in the world and cause more and more havoc. So there's that variable. As every day goes on, more and more humans are vaccinated against COVID, and that's going to reduce that. On the other side, what's going on here in Canada, more and more people are getting infected, more and more people are being vaccinated. So on the whole, there is more and more protection against the virus, which means that successive waves so far have not shown increased mortality in the age of Omicron. This wasn't true before, but now with Omicron, we are seeing successive waves that are not associated with higher mortality. They're associated with lower mortality so far. So what we expect to see is waves that are further, that will continue to happen, perhaps in many, many cases, but not associated with the degree of mortality. At some point, we're just not going to measure waves at all because it has less and less impact on what we do. Certainly in the wintertime, we're going to be more and more mindful of that because the numbers will be very high. But outside of that, you have to wonder at what point does a wave not really relevant to our health in the most immediate way, where we have a baseline level of public health measures that protect us, that we continue for a while, in which case we don't need to actually pay close attention to the numbers from day to day.
Well, my question to you then is, what do you know in terms of, is there a threshold to, go from, or to, that has to be met, I guess, to release us from being in a pandemic?
Yeah, that's a great question because every country has taken a different approach to this. Certainly WHO has their own approach in terms of the numbers, number of people infected, the deaths they expect. On the global scale, the deaths have fallen dramatically. So from that point of view, the pandemic is winding down in that sense. But the total number of cases are not winding down. We're still seeing very high numbers. So what is it going to take us to be out of the pandemic? It really has a lot to do with the public perception and public safety. Of course, the objective number would be deaths and hospitalization, is that we'd want to continue to see that number drop as the pandemic goes on. But outside of that, it's really the public opinion and public approach is that as long as deaths come down, when is the public going to feel comfortable with continued return to pre-pandemic life? Of course, there's always an important discussion to be had is what aspects of pandemic management do we want to retain, regardless of the fact of whether you call it we're in a pandemic or not. What are the things we want to keep, change compared to what we were like before pandemic? Because going back to pre-2020, there's a lot of benefits to that, but there's some things we may want to keep.
All right. Always fascinating to speak with you. Let's get to our audience questions. And we'll do our best to get to as many of them as possible. Let's throw up our Slido interface. There we go. Thank you to everyone who has submitted questions. That's not for me to read. Next one. Should we reinstate masking soon with wastewater indicators on the rise?
Yeah, I think it's important to think about what is the actual impact of masking and in which settings. In high-risk settings, I agree masking is going to be left in place for a very long time. So hospitals, long-term care facilities, congregate care facilities, those kinds of places, because there you have a persistent population of vulnerable people who can pick up COVID and have bad outcomes. But in the general public, even if we wanted to introduce mask mandates, I don't think they're going to be very effective because there's a lot of fatigue among the public in wearing masks. Certainly, it's very slowly declining as the summer persists. Certainly, we're still seeing a lot of people wearing masks, but the public appetite for this declines. I think it's important to recognize that masking probably blunts to some degree a wave, but we will never be able to actually completely prevent a wave. That's really just impossible short of doing very, very strict measures. So masking can have some benefits. I don't doubt that in a public sense, but I just think that people should have reasonable expectations of what a mask mandate can accomplish in the future. For example, if it was introduced in the winter.
Next question. When do you think we'll have a new vaccine that is more effective against the new COVID-19 variants?
Based on the statements from the federal government and the provincial government, they anticipate it'll be available in the fall time sometime, but there is no guarantee of that. So what we're looking at, as you mentioned earlier, is a bivalent vaccine that includes the original strain that we're using in our vaccines, plus a new Omicron-related or Omicron-based vaccine strain. And that would be, ideally, it would be in sometime in the range of October to November. That would give us time to vaccinate many people in preparation for the winter. But of course, there's no guarantee. It has to go through approval processes with the federal government. We've seen delays in the past. On the other hand, we've seen things happen quickly too when it came to the vaccine rollout in about a year and a half ago. So it could be positive news for Ontario very soon.
From Flavia, should we be lobbying government to impose indoor masking? So many people are no longer wearing masks.
Yeah, and that's a great question. Going back to my earlier response, I think people have to understand there's going to be limitations if we try to introduce it at this point, that there is the public interest in doing this isn't as high. One other thing to keep in mind is that when public health makes recommendations in a free and open society like Canada, there is always going to be some degree of pushback. Of course, there's extremists who simply never want to wear masks in the first place, but then there's your average person who simply just kind of is tired of it all, and they're not, paranoid, or they're not conspiratorial in any way, but they just simply are tired of doing it. So when public health recommends something, you really want to use that messaging, that time you have with the public's attention, on something that is very efficacious. So for example, when it comes to the vaccination, really the highest impact when you think about it now is on giving third doses to everyone and fourth doses to the vulnerable. So when you think about masking, when would we want to do the masking? You really, if you do want to roll out masking as a mandate, you really want to use it when it's going to have the most impact. And if it is decided, probably the winter time is that time where it's going to have that most, and it's also the most logical time to roll something out. Again, recognizing that there's going to be limitations in such a mandate, but I think it's important to recognize when is the biggest bang for your buck, and that would be the time, I would say.
Yeah, well put. Next question. A resident in my seniors building tested positive. After 5 days, she felt better and tested positive again. She says she was told tests could still show positivity for months, though she would not be infectious to others. Comment, please, and how many days should one isolate in the new normal?
Yeah, it's pretty, in terms of PCR, certainly you could test positive with your PCR for months after you've had COVID, but that doesn't necessarily reflect the infectivity. So for your average person, the infectivity is somewhere in the range of 8 to 10 days. For people who are immunocompromised, it's probably a little bit higher, 10 to 20 days, depending on how severe your symptoms are. If you are well enough not to be admitted to hospital, it's very, very unlikely in most cases that you're going to be infective past 10 days. And that is the recommended period of isolation. It's been that way for a while, although it's been shortened due to other various considerations during the pandemic. But basically, that's what the science still tells us, is that that's the approximate range where people are infective. Getting a repeat PCR soon after you've had COVID doesn't really add anything, because it's likely that you remain positive for a while. Within 90 days, we don't recommend you get a repeat PCR in most instances. If you get new onset symptoms, completely brand new, you may consider getting testing in that setting, but the interpretation of that test has to be done very carefully.
Next question. On CP24 today, I heard about the research study at U of T and Utah. They said the study showed that we should wait for a new booster that lessens the effects of Omicron and its subvariants. I have 3 shots. Should we wait? I guess that depends on their age and whether they're immune compromised.
Yes, if you're rated at the age of, if you have 3 shots already and you're not over the age of 60 or 50, hard to know, somewhere in that range, and you're not immune compromised, it is a hard question to answer. When is the best timing? Again, if you do get a vaccine right now, it does provide you some short-term benefit. Does getting 2 vaccines in short succession between July and October, does getting that second dose kind of hinder the effect of the first one, or hinder the effect of the second one? It's not clear, but it's not likely to be the case. It's not likely that having a vaccine in that short time is going to impact you negatively in any way. The only exception to that is males aged 18 to 24, which have a 1 in 5,000 risk of myocarditis. That's really one of the most important considerations in my mind. In that age group, you might want to think twice of getting repeated doses. But in every other age group, in females, for example, the risk of myocarditis is quite low. So the overall risk associated with mRNA vaccination is low enough that you would say that having a shot in July and having a shot in October is probably safe. But again, it's not an easy question to answer. You have personal issues that you might want to consider. So let's say you're a young, healthy woman, age 30, but you're going to be pregnant. Or your partner is pregnant, for example. That might be a consideration for why you want to get vaccinated now compared to waiting till October. Let's say you're going for a procedure in the next few months. Let's say you hope to travel to a high COVID area in the next few weeks. These are all the considerations you might want to make for your own personal safety about whether you're going to be vaccinated now compared to October.
If we are unmasked, how safe are we outdoors, like on the island ferry, around lots of other unmasked people?
Yeah, if the space that you're in is not enclosed in outdoor space, if you're not very close to one another within a few feet, it is likely going to be completely fine. Personally, I do not mask outdoors unless I'm in those settings. I mean, I don't go out if I'm in an area where there's somebody very close to me. For example, like if you're sitting on the ferry and there's lots of people shoulder to shoulder, I would mask in that setting when there's high cases like there are now. But if I'm out in the park, on the island, or walking down the street, I don't mask in that setting. So really just think about who's near you and how close are people to you in that setting.
I just heard of a Danish study that concluded that by getting repeated boosters, one's immunity to other non-COVID viruses is lowered. I'd like to hear comments.
I don't know the specifics about that study, but clinically that hasn't been shown. I mean, we haven't seen a rise in other respiratory viruses previously as a result of people getting boosters. What happened this year in the springtime is that a lot of the other respiratory viruses rose in prevalence, but that wasn't related or not thought to be related to the fact that people got boosters and they were less immune. It was because there was a lot more exposure. People were out and about, daycare, schools, all those settings were back to full force, less measures. So there's more transmission between those people, between kids, between adults. So the presumed reason why all these respiratory viruses rose recently wasn't related to boosters, and it would seem unlikely. We don't have a model for that in other vaccines. So for example, if you get flu vaccination, your immunity to other respiratory viruses is not presumed to be lower. Or if you get hepatitis B vaccination, your immunity to other infections is not lowered. So I would think that's an unlikely conclusion from getting boosters.
Next question. I know people with long COVID who could not get a test diagnosis very early 2020 or not eligible for PCR with restricted testing, yet most long COVID clinics require a diagnosis. Where can these people access rehab they need? In Toronto Star, August 2021, Dr. Chung mentioned CanCov clinics help. Alon, I don't know if you can answer that. I do know, though, that unfortunately, because Dr. Chung can't be here, we can't give you a direct answer, but the foundation is happy to follow up with you afterwards with the answer. Unless, Alon, do you?
No, I agree. Contacting the foundation contacting Dr. Chung, since she is a world expert on the topic, would be a good idea.
Okay. Yeah. And she does run a clinic. So that's obviously an option. Hello. For people over 70 years, what is your opinion on rotating the boosters? This is a good question. Moderna, then Pfizer. Does it have any benefits?
So about a year ago or so, it was established that between Moderna and Pfizer, the doses are virtually interchangeable. They're both mRNA vaccines that don't have really much difference in terms of their efficacy, really insignificant in overall sense. If you get the first dose of Pfizer, it makes sense to get second dose Pfizer and third dose. That's generally been the approach. But if for whatever reason supply is low, you need to get the other. There is no theoretical reason why you shouldn't. We don't really have an answer for this when it comes to fourth doses, as we do for first and second, which was based on good data. But presumably, there's no reason to believe that it should be any different with third and fourth doses. So mixing them up, there's some suggestion literature there might be some benefit, but there's really no difference. You can get any mRNA dose, whatever is offered to you, you could take it for your fourth dose.
Okay. From Judy, does the serum in the vaccine change according to new variants, similar to how the flu vaccine is made each year? So is the fourth dose different composition than that first dose?
No, effectively, when you look at a flu vaccine or COVID vaccine, what it is the antigens presented to your cells are going to be different. The mRNA, the sequence, that's what's been altered. The actual composition of the preservatives that's in there that are made out of things that we're commonly exposed to that are very low in terms of allergenicity, those things aren't going to be changed. Part of the problem is that when you introduce a new vaccine, you have to get FDA approval. One of the things you could do to make that process a little simpler is to make as few changes to the vaccine as possible, just like with other drugs. So it wouldn't be in their interest to really radically change the vaccine, aside from changing the mRNA sequence. That's really the key thing, because when you alter the mRNA sequence, that alters what your cells do with it, presents a different protein, creates a different set of antibodies. And that's really the purpose of this different kind of variant vaccine, is to try to match the variant that we recently were exposed to. Unfortunately, it's a cat and mouse game or a whack-a-mole. This is a never-ending problem. There will always going to be variants arising from COVID. The vaccines we come up against them will never be great in terms of long-term immunity to picking up the disease. That's just the unfortunate reality. It will remain, so far, very good at protecting you against dying, but we're always going to be chasing our tail in terms of protecting you in the short term against picking up the virus.
Which is very much the cycle we have with the flu vaccine every year, it seems.
Yes, similar to that.
What do you think of vitamin C injections that are being used in California hospitals on COVID patients? Do you think that this method would ease long-haul COVID symptoms?
At this moment, we don't have any evidence-based therapies to prevent or treat long COVID. I mean, the only one we have that prevents it would be vaccination. Outside of that, there are no treatments for people who have long COVID. The challenging aspect of long COVID is that there are a group of people who are experiencing symptoms after COVID, and a large industry, unfortunately, that will take advantage of people because people are suffering and they're looking for answers, they're looking for treatments. This is true even before the pandemic, where people with various other ailments sought treatments for their condition and were taken advantage of. I think it's important for the public to realize that there isn't any proven treatments at this moment for it. So if you choose to undergo any one of these therapies, it's at your own risk. And if you choose to do that, it's important for you to recognize what are the risks associated with that therapy. It could be that there is benefit at some point or proven to be benefit at some point from one of these therapies. But at this point, all we know, we really don't know yet. And if you do expose yourself to those treatments, you have to understand what are the potential risks to you.
So it sounds like a note of caution when it comes to the long haul COVID treatments.
Yes.
Can you share any insight into nasal vaccines and the likelihood of production over the next year?
Yeah, that's a great question. I don't have any specifics, but it has been worked on for over a year now, and we might be able to see it later this year or earlier. The use of nasal vaccines has been for other vaccination types. For example, for polio vaccination has been used in low-income settings, such as in sub-Saharan Africa in the past, for ease of administration. So here in Canada, of course, they could also have a role in terms of their ease of administration. Also, if people have had reactions to previous types of vaccines, maybe this provide another kind of platform. But it's still too early to tell about when we might see those used in practice here in Canada, in the next 6 months.
Can you share strategies for getting government to react to the overall healthcare crisis and the mass exodus of nursing staff? Not quite on point for us, but I'm sure you have some insights into that, Alon. You see that every day. Yes,
I mean, I don't have any expertise in human resources or public health management in this sense, but all I could say is I echo the concern that in the healthcare field there is a problem where healthcare workers unfortunately have been burnt out as a result of working during the pandemic, and we're seeing shortages across the board, not just in Ontario, not just with nurses, but with other healthcare professionals. And this is a problem that it's across Canada, it's even across the United States as well. So I unfortunately don't have any therapies or any insights on how to do this. I won't pretend to be an expert in this area, but all I could say is that I agree that this is a major concern for our healthcare system at this very moment.
Absolutely. We have had this long haul COVID for 4 months, and the fatigue is very difficult. What can we do to increase our energy levels?
Yeah, it's a very important question. And again, we don't have specific therapies as in drugs, but often in these cases, for people who have any kind of post-illness fatigue or difficulty with ambulation, as is the case with people who survive the ICU for whatever reason, whatever illness they had, they are sometimes offered physiotherapy or those kinds of programs to help people improve their ambulation, return to the energy levels, return to their baseline function. This is offered to people in sort of a allied health interdisciplinary fashion, with clinics that help people get back to the function, back to where they were before they were hospitalized. So unfortunately, I don't have any specific resources that could be offered, but again, Dr. Chung, who is very familiar with this problem, can probably provide some insight on this.
This is a great question. Is it still a pandemic of the unvaccinated?
In Ontario, that's really not the case anymore, because the vast majority of Ontarians are now vaccinated. So really what's going on now is that people who have high degrees of vaccination but do not have good response to the vaccine are the ones who are unfortunately having poor outcomes. So people who are very elderly or highly immune compromised, such that the vaccine isn't doing much for them, those are the people who remain susceptible to poor outcomes. As for the rest of the population who do have a durable response to the vaccine, those people, again, the crux of the problem here is that even if they're not admitted to hospital, they are going to pick up COVID. And this is going to be a continuous cycle that is going to be very challenging to completely eliminate. Again, we talked about strategies to reduce waves, but to completely eliminate that, it's really quite impossible unless you use strategies that are really totalitarian in nature. So really, it's a question of how do we reduce the waves, not eliminate the waves, and how do we reduce morbidity associated with those waves. But that's with the pandemic. The vast majority of people who are picking up COVID now, fortunately, do not have bad outcomes, do not die or are hospitalized. That's really what the pandemic has transformed into, a pandemic where high degree of morbidity and mortality. Now the pandemic has transformed to a very, very transmissible disease that affects many, many healthy people that does not result in death.
Mm-hmm. All right, the next question is another long COVID question, which I think we'll leave to the foundation to respond to. Next one, is there any positive news? No, though, not that one. Okay, do you think we'll return to vaccine mandates in the fall?
You know, the problem with vaccine mandates is that, so again, the purpose of getting vaccinated is, one is to protect yourself from dying or being hospitalized. The second is to protect you in the short term from picking up the virus. The purpose of a vaccine mandate is really to try to reduce transmission in the public setting to protect people. So for example, in a hospital or in a public sports arena, is to try to reduce transmission in those settings. Mandates really make no sense whatsoever anymore because, you know, for example, I got my third dose in November. That dose is not doing anything for me now, or very little, I should say, in terms of protecting me against mild illness. I could pick up the virus quite easily now. It is protecting me from dying, but not from mild illness. So really, what's the point of a mandate if the primary purpose was to protect you against transmitting it from other people? It doesn't really make sense anymore. So unless you're going to institute a mandate for people who got vaccinated only for 3 months ago or 6 months ago, you really can't do it. And it really, from a public health perspective, you can't have a mandate for people to get vaccinated every 6 months. That's not going to fly for the vast majority of the population. So mandates, for the most part, they might still make sense in very, very limited settings like hospitals, but in general, in public settings, it's not going to make much sense.
Yeah, certainly in hospitals, for sure. Next question. Phlegm seems to be a constant issue now after COVID. What can be done to overcome this problem?
Yeah, there isn't any specific treatment in terms of medication. There are some drugs that are taken for phlegm. People try to thin out your phlegm, regardless of the cause, whether it's COVID or otherwise, that can be prescribed by physicians. Those do have side effects. Essentially, it tries to loosen it up a little bit. Generally, people do have a bit of cough and some phlegm after they have COVID, but generally that's self-resolving after a few weeks. So if it's really a chronic problem and this individual are experiencing phlegm or a high degree of phlegm weeks and weeks after experiencing COVID, then they could ask their doctor for medication. Of course, these things could have side effects. They're not generally used for this indication. They're used for other indications. So just important to recognize that probably this will get better on its own.
I travel for work and I haven't been able to alternate the vaccines since some countries don't accept the mixed vaccine. Is it okay if we don't rotate vaccines between Pfizer and Moderna? And what are the risks?
Right. If you don't rotate between them, that's certainly fine. If you just use Pfizer all the way or Moderna all the way. And again, as I mentioned, if you use a mix of Pfizer, Moderna, that's certainly fine. There isn't any harm associated with that. And there isn't any reduction in efficacy. It'll work just fine if you choose to have a mix of the Pfizer or Moderna together.
Can't some restrictions be a permanent thing? Example, limit store events, museums, etc. capacity so as not to have huge crowds to control cases? Or can't we keep social distancing around for good?
I think probably in some settings, you want to keep distancing around for good. In the areas where the high degree of mortality and morbidity is associated with transmission. So hospitals, for example, would be a place where you try to maintain it as long as you can, especially if you're building a new hospital or a new clinic, you try to maintain those things. But in the long term, in public settings, it's probably not feasible to maintain only because our buildings were not well designed for this kind of thing. And you also have to wonder to what degree it's going to be efficacious. Some things are just not ever going to be designed that way, like a stadium, for example. You're not going to ever be able to design it that way, or other kinds of restaurants, for example. So we're really limited by that. I agree that distancing does have the impact of reducing transmission, but there is a limit to that. And again, if this disease is becoming less and less dangerous in terms of morbidity and mortality, then we have to think about what are strategies to be a more sustainable strategy. How can social distancing be integrated in some settings, but perhaps not all settings, to make people comfortable and make them safe too?
Will rapid antigen tests continue to be used, or will this test need to be adjusted to test for the new variants?
So far, there's been varying efficacy associated with a rapid antigen test with Omicron. Pre-Omicron, although we weren't using it that broadly before Omicron, it was quite good. When Omicron arrived, there was some decreased sensitivity in the test, still very good specificity. In the future, they may want to change the antigen and update it, the antigen test. But the problem is, again, is that this is a game of whack-a-mole, is that this variant will change to another variant. Just in the last 6 months, we've switched from BA1 to BA2, BA3, now 4 and 5. BA1 and 3 are virtually gone in Ontario, even though that was the most common strain back in January. So by the time you build something against a specific variant, it's already moved on. You already found something else. For example, we had antibody therapies for BA1. In 2 months' time, all that antibody therapy that the government bought was entirely useless because BA2 arrived, and that was that. So whatever you're designing to try to protect people against variants has to be good enough or effective enough and not specific to a variant, because then it's just going to move on to something else.
What can we learn from other countries around the world who are dealing with new waves? Sounds like COVID doesn't exist in the UK. Should we take a similar strategy of ignorance is bliss?
Well, I think the bottom line with COVID, most people's approach to COVID is to do whatever we can to protect the hospitals. That is one of the most important principles. In other words, to reduce the death and hospitalization associated with COVID and its consequences associated with the hospital itself. If we have so many people hospitalized that we have to cancel surgeries, cancel chemotherapy, cancel tests, then you really need to do whatever you can in public health measures to prevent that. That's really the bottom line. And if you're not experiencing that, if hospitals are not overwhelmed and people are not experiencing significant morbidity, then you probably don't need to do the high levels of lockdowns and restrictions that are required for keeping COVID down. The challenge is that as COVID has progressed, with Omicron progressing, it's become, generally speaking, more and more transmissible. So your measures are becoming less and less effective. So what are you practically doing when you're adding these restrictions, right? We have to be very clear, very honest about it. For example, with masking, if we do introduce a mask mandate in the winter, we have to be very clear that it's not going to eliminate waves. It's going to have some degree of reduction of a wave, perhaps. That's really what the masking is doing in a public setting. So when you're talking about other countries and what they're doing, we have to think carefully of how is that going to impact us in terms of our COVID numbers, and do we need to do it to protect people from dying and having serious morbidity.
Personal question for you. Oh, no, we skipped one. Okay. If I am the only one masking inside in a busy public space, am I getting any protection from the mask?
Absolutely. If you're wearing a well-fitted, tight mask on your face, and even if no one else is wearing it, you're still getting protection, even if nobody else is wearing a mask. Of course, it's preferable if people had COVID that they wear a mask. Of course, we shouldn't be going out in public if we have COVID, but if that's the case, it'd be preferable, but you're still getting a high degree. And to give you an analogous situation, prior to COVID, when I or anyone else in a hospital saw a patient with a respiratory virus, I would enter the room of the patient and I would wear the appropriate PPE, including a mask, eye protection, gloves, gown. The patient would almost never be wearing a mask. And this was considered safe. And in fact, it was safe because we didn't see outbreaks as a result of this. And we had lots of patients admitted for viruses like the flu. So this was the standard of care. This is what the standard PPE was for all healthcare workers, essentially in all of North America. So there is certainly a high level of protection associated with wearing a mask, even if the person you're in contact with does not have a mask.
And this last question, a personal question for you, Alon. Are you feeling frustrated with the current state of affairs of COVID in Toronto, or are we in a generally reasonable, manageable place as a community?
It all depends on what your point of reference is. If your point of reference is April of 2021, then we should be very, very happy with where we are right now, because that strain and that time we were completely overwhelmed. Our ICUs were overwhelmed. We had to cancel tons of surgeries, and things were looking very bad in terms of mortality. A lot of young, healthy people, a lot of people across the board were getting bad outcomes. But now it's a different story. Now the mortality is much, much less. Now there's fewer people being admitted to hospital with COVID. So from that point of view, I'm very happy that we're not seeing as many people dying. In fact, it's far, far less. In fact, and also the vaccination numbers have improved since then, of course. The unfortunate thing that it's making me frustrated is more the aspect is that we're we're still seeing lots and lots of cases. And as a healthcare worker, infection control physician, unfortunately, still resulting in transmission in hospitals. And that cycle for now has not been broken yet. We're still seeing introductions from the community into the hospital. So in the public sense, a lot has changed. The risk has dropped dramatically for the average person in the public. In the hospital setting, unfortunately, it's going to be a while before that changes. So it's mostly good news, but unfortunately, these waves are still causing some degree of problems in hospital and acute care settings.
And a reminder to support your local healthcare worker. They've been through a lot the last 2.5 years in addition to this. All right, we've come to the end of all our questions, which is, I think, almost a first. To all of you out there, thanks for joining us. And to Dr. Alon Vaisman, UHN Infection Protection and Control Physician, thanks so much for taking time out of your busy day to share your insights and expertise. Thanks, Alon.
Thank you very much for having me.
This live stream will be available for viewing on the UHN Foundation Facebook and YouTube page. And finally, donor support. Your dollars fuel the groundbreaking research initiatives of our award-winning UHN scientists who are working to discover new treatments and cures for patients every day. So their pioneering work is what Newsweek magazine used to rate Toronto General Hospital as the 4th best hospital in the world for the 3rd straight year. So if you're able to give, we ask you to consider making a donation. Go to www.uhnfoundation, that's all one word, uhnfoundation.ca/help. Thanks for tuning in. We'll be back again. Stay tuned to your email inbox for a notification of the next live stream. In the meantime, be kind, practice physical distancing and masking up if you can, and get your vaccination. Stay safe, everyone. We'll see you again.